Welcome to Pulmonology Read Aloud. My name is Dr. Anshu Maneja Arora, and this is my channel dedicated to learning pulmonology in the easiest way possible. Today, I'm going a little bit off the track and not reading aloud a published document, but actually reading aloud my presentation on interpretation of sleep study report. Now, interestingly, I presented this in a sleep workshop organized by the Indian Chess Society, and a lot of the PG residents attending there came to me and said, "Ma'am, why don't you have it on your channel?" So here it is for those who missed it out, and I hope it helps you in your practice. So basically, when we are reading a sleep study report, one has to remember that it is actually a recording where we are trying to understand the biophysiological changes which are occurring during sleep. So amongst the biophysiology in sleep, what we are looking at as pulmonologists while reporting is mainly number one, identifying how the patient's sleep is, the overall quality, architecture, staging of the sleep, analyzing the state, the patterns of respiration, whether the patient has any sleep related breathing disorders, and also trying to analyze other problems such as movement disorders or any other neurological issues that we can come across. So let me give you a brief review of how I read a sleep study, and that is in very easy 6 steps. First of all, when you receive a sleep study report, you have to look at the study quality and whether the patient has slept for enough time for you to actually report that study. Study quality is very, very important because a lot of times you may have had so many electrical disturbances and signals that you may not be able to stage the patient properly. The patient could have slept for a much lesser time and we may not have recorded the entirety of the sleep. For instance, he did not have any REM sleep at all. So if you are trying to score a patient for obstructive sleep apnea, you may actually underscore him. So it's very important to look that the sleep report has a good quality reading. And the total sleep time is at least 4 to 5 hours for you to go ahead and report that. The second thing that I would look for is the sleep architecture. So when we are scoring the report, we usually go ahead and do the stage scoring first before we go on to look at the respiratory summary. In the same format, when I see a report for me, which has come to me for reporting to the patient, then I would first look at the sleep architecture because a lot of times when you're looking at patients with insomnia, you're looking at patients with COMISA, where you have a combined insomnia and sleep apnea, you may miss out on a lot of things if you don't pay attention to the architecture. Even in patients with chronic respiratory diseases like COPDs and ILDs or asthmatics, when you're looking at the overall sleep of that patient, the sleep architecture is so, so important. The third thing then I would go on is to look at the respiratory summary table. Now, I know that when you start reading the reports first, your first thing that you go on is you look at the AHI. But we have to avoid that because there's so much information which comes from the respiratory summary table where you not only know about the type of events that the patient is having, which helps you classify whether he has a predominant OSA or a predominant CSA or a complex sleep disorder, but you're also able to find out if this patient has had a particular type of event which is more predominant or something which could be a little extreme, say as he's having Cheyne-Stokes respiration pattern or any other breathing patterns. After that, I put my eye on the indices, and indices are very important, yes, but it's not only the apnea hypopnea index. I would want to see the respiratory disturbance index. I would want to see the PLMI. I would also want to see REM related AHI, and other problems specifically in position as well as in the REM stage of sleep. So that is something that I would next look at. After that, it's important to look at the desaturation burden. There's more and more data and studies which are pointing at how the oxygen saturation, or rather the level of desaturation, is a very important uh, factor to understand the overall morbidity and mortality of patients. So the desaturation burden is something that we have to really, really be concentrating at. And then I would never forget to go back and look at the raw tracings and ensure that whatever we have scored is correct, especially when it is not me who is scoring the report directly. If there is somebody else, a technician, scoring it on my behalf, I would go back and check the tracings to ensure that the final summary is with the right report. And don't forget to match it with the clinical context, because you may actually have unexpected results. So that's how you can formalize a plan to read a sleep study report. Now let me take you through each section of the report, because that's what I'm talking about here, is how to look at the report and know what it's dealing with. So this is how a summary report looks like, and I'm just going to show this because we'll come back to it, because this is the last thing that we do is after reading the report. This is how the report actually looks like. It has a diagnostic portion. It has a portion where you have the respiratory summary. It has a portion where you have the arousals, the oximetry data, and other data, and then this very important slide, and then you have all of the tracings that I generally definitely add at the end of my report. So first of all, when you are preparing such a report, what has to definitely come is the name of the sleep center, the lab, or and the contact info of the center, so that anybody who wants to, find out more about the report or communicate with the doctor who did the report has access to it. The second thing that you must have is the patient name and the BMI. And we know that the BMI has very, very strong implications, because we do see a lot of sleep disorders in obese individuals. So we want to know that. The date of the study, the type of the study, which is very important. The type, we do studies across level 1, 2, 3, and 4. I am talking about polysomnography, which is level 1 and 2 here. So I would want to know whether it was an attended study or an unattended study, whether it involved a video monitoring or not. And so that's important. The other thing that you want to ensure is that there are technical comments on the parameters that have been checked and the physician's name. And yes, we'll be going through how a report is structured, so you'll have the second half there. These are commonly used abbreviations, and there are many more abbreviations also. But when you are reading the report, sometimes you may get confused between certain abbreviations, and it'll be important to have a note of it. These are the normal adult PSG indices, which are ASM based references. But remember that these are for a reference adult population. When you age, you may have a difference in these indices. For instance, if you look at elderly, you may have a less REM sleep, you may have more wake after sleep onset, you may have a change in the slow wave sleep. So that all has to be again taken in clinical context. And even in children, you may have a different indices and a different value to suggest central sleep apnea or an obstructive sleep apnea. It's totally different in pediatrics. So you must take that in mind. And this is for the adult population, though. Now, this is something that I really, really look out for. And this one is from a split night sleep study, and I have purposefully put this here. But when you look at a diagnostic sleep study, you will get a different hypnogram. A hypnogram is like a page which gives you an overview of the entire night, and it's a very good summary. And a lot of times you may get so much information from hypnogram that it makes the need for looking at individual values much less. So I would go on and turn the pages and go to the hypnogram first before I actually start looking at the values. A hypnogram is a very good summary of all events, which include the EG, as you can see here, where you can note the stage of the sleep that the patient is, and then there is this the timeline which tells you that when did it occur. You see the heart rate, you see the saturation levels. There's also a marker where you know whether it was 90 or 80 or further. The central events, the scored obstructive events, the mixed events, and obviously this is generated after you've scored the report. And in this talk, we are not talking about scoring. Then you have the hypopneas, the leg movements, the flow limitations, the arousals, the patient position. So whether he slept on the left or the supine or prone, which again has a lot of implications in phenotyping the OSA. And because this is a split night with BiPAP titration, you can see the IPAP and EPAP and how it went along. Now, see how you can see this. There's a stark uh, kind of irregularity in the sleep architecture of this patient, with most slow wave sleep and REM sleep all through. So, there's definitely a lot of advantage of looking at the hypnogram, because you are getting a nutshell of how the patient slept at night and were there any nighttime problems. These are a few more hypnograms, and here you can see how well organized this sleep architecture is, with regular REM sleep and the patient transitioning between wake to slow wave sleep and then deep sleep. And here also in this hypnogram, with the timeline, you can see and you can actually correlate with the patient that yes, you did have a good sleep or you did not have a good sleep after say 3 a.m., and so on and so forth. Now, coming to the report sections, the first thing that you will see is the patient data. Now, patient data is so important not only as an identifier, but also because you get information regarding the BMI, you get information about the total time he has had in bed in this, and you also get a case history. And remember, as I said, clinical context, very important. So, you can clinically have a context as what was the history of the patient, and then with that patient data, you can score and come to a conclusion in the end. The next thing that you must have is a sleep study technical details. So, technical details include the technician's details on how many channels were used, what was the level of study per se, and what all parameters were done. And it's very important to have it in your summary report. The third thing in this diagnostic portion, you can see the sleep summary. So this is the sleep architecture part that we are seeing, and you get important information such as the lights out, the lights on, the total recording time, and the total sleep time. Now remember, the total recording time is different from the total sleep time, because the total recording time is actually the time in bed, but the total sleep time is actual time in sleep from the right from the onset of sleep, which is denoted through the EEG. So we use this parameter, the TST or the total sleep time, to look at the indices such as the AHI. And so this is something that only a polysomnography can give you, and a level 3 and level 4 study cannot. So whenever we are calculating indices, this is the time that we are using. And you also get important figures like the sleep efficiency, the sleep latency, that means the time taken to sleep, the REM latency, very important, specifically when you're doing MSLT and you're looking at narcolepsy. What's the REM latency? The wake after sleep onset. And here you're getting all the four stages, the N1, N2, N3, and REM, with its duration and with its percentage, which we were seeing basically on the hypnogram. The same thing is depicted on this pie chart, and you're also getting the latencies here for you to see. The next is respiratory events, and when you're looking at the respiratory events table, you get a division between the apneas and the hypopneas, and then they are further divided into the non-REM and the REM stage and the total. Now, as you can see in this patient, the central apneas are absent, there are no mixed apneas, and there are predominantly obstructive apneas, which here I can see is a total of 243, but it's not that the REM events are much more or predominant. So I can also rule out REM related, predominantly REM related OSA, and I know that the patient has had obstructive events throughout sleep. Here you get a total of hypopnea events and you get a total of RERAs or respiratory event related arousals. Um, which essentially means that these are those events where there is a sleep fragmentation and disturbed sleep with microarousals without meeting the criteria of an apnea or hypopnea, which are not there in this patient. And then our favorite, the indices, where you're seeing the apnea hypopnea index, which is very high in this patient. It also gives you a split between the AHI in non-REM and AHI in REM sleep, again very important, and the total RDI, the respiratory disturbance index, which nowadays is gaining more importance as compared to the AHI. And here also you're getting a count with the arousals for you to have an arousal index. These are two other reports which are showing the respiratory analysis. So you may see them differently with different devices. The structure of the report may be different, but essentially the information that you get is much similar. So here also you're looking at obstructive events, mixed events, central events, the score, the RARAs, and the same information essentially. So don't be boggled by the way the report looks because it's a daunting 13 page report for beginners, but then essentially this is the information that you're getting. And you also look at the duration of these events to see whether this is a phenotype of the patient where he may not be having many events, but the duration of the events is so long that the patient may ultimately have symptoms secondary to it. Now, this is a very important table which gives us respiratory vent by position. But see, what are the two things that I've mentioned before that? Chain Stokes breathing and hypoventilation. Now, in case you do observe these, the technician does give remarks in the study scoring, and you see these, you have to report these events. And in the body position summary, again, it's very important to see whether the patient has more events in one particular position, which is mostly the supine position when it is POSA or position related OSA, where the supine AHI is much more than the prone AHI. So here you get this information whether the patient on his back is getting more events versus on any other position. Then comes the oximetry data. The saturation is so important. And here, one we see is the ODI, the oxygen desaturation index, which is the number of oxygen desaturations based on the total sleep time. And you also get the minimal SpO2, you get an average SpO2, and you get something which is called the T90 or number of desaturations where the patient's saturation fell less than 90%. The time in sleep where the saturation was less than 90%, which is a very significant parameter which tells you about the hypoxic burden. It also tells you how long the biggest desaturation was, such as in this patient for 15 seconds, what was the average desaturation, what was the average minimum desaturation, and was the nadir the lowest saturation level. Now, these are two different reports from two different devices or sleep labs, and here there is a chart mentioning less than 90, less than 80, less than 70, and but essentially what we are looking at how low and how long and which phase was it. So again, coming back to same information only depicted in different formats. Now, the other parameters are also mentioned, which include the heart rate, where you know the average heart rate, the highest rate, the lowest rate. You can pick up ectopics, tachycardia, all of these. If they are scored, you will see them and can clinically correlate. And the periodic leg movements, the number of movements, the movements associated with arousal, and the PLMS index, along with the arousal index in each stage of sleep and total. When we are looking at UARS patients, you may have a low HI and you may have more arousal index. So again, a very important factor to determine the phenotype of your OSA patient. Now coming to pattern recognition. Now we remember that polysomnography is not just looking at the indices, because we know that there are many subtypes of pathophysiology which are working to cause OSA. It's not just upper airway obstruction or just a muscular pathology. It could be the arousal threshold, it could be the loop gain issue. And because it represents various disease phenotypes, we are trying to integrate all the knowledge received and all the data together to also phenotype our patient. So here, one would remember that the apnea hypopnea index does not capture the depth, the duration of hypoxic burden. So it is not sacrosanct. It does not tell us about which stage is predominant. It does not tell us about any other interventions one can do. So, two different patients with the same AHI can actually have very different risk factors, very different outcomes, very different treatment needs. So, your PSG report has to guide as to what should be the next intervention. So, if you look at metrics, AHI is now gradually being slowly and slowly overpowered by a lot of new indices, such as the hypoxic burden, the hypoxic load, the oximeter derived pulse rate variability, the RDI, or the sleep breathing impairment index, and others. So, in future, we may have more of these validated tools that we may have to integrate in our reporting. Now, this is a general overview of how an OSA or a CSA or a mixed apnea report presents, and how a patient with sleep hypoventilation will present with mostly obstructive events or central events, or in a mixed apnea, starting with central events and turning to obstructive events, or a sustained hypoventilation with a sustained desaturation in OHS. But there will be a lot of times where you may get other patterns. And so when you're reporting that report, you may have to mention those. For instance, there may be instances when the AHI is low but the RDI is high, typical of the upper airway resistance syndrome phenotype. There may be REM predominant OSA with overall AHI being low but REM AHI being high, and also warranting treatment. There may be a positional OSA where the supine AHI is more than twice of the non-supine AHI, which may also lead to particular positional therapy as a treatment. Or there may be high hypoxic burden, like in patients with chronic respiratory diseases. So this again has to be interpreted with the report, and one has to know that. So this is a general summary report, and there are many arenas where you can improvise your report. For instance, in this report, you may not be seeing a clinical history, which may be important and can be included, where you mention why that patient was subjected to a sleep study. We'll also mention the procedure and the technical comments after writing the patient demography. And here we're basically conveying what type of sleep study level did we do. Was it a portable acquisition device, or or was it done in a sleep lab? The next thing that we're looking at is the report section, where we're talking about the sleep architecture first. We're talking about the sleep latency. We're talking about the sleep efficiency. We're talking about REM latency, which was also affected in this individual. And we are also looking at the duration of REM sleep, which was very low for this individual. So we are trying to give a basic understanding of the sleep architecture. The next thing that we are mentioning is the diagnostic part of the report, is the indices, like in this patient, the AHI being high. And we're also trying to mention the lowest saturation, the nadir. We're also mentioning what kind of events were there. As I said, you need to mention the pattern. We're mentioning whether snoring was present. Then, because this was a split night study, we're mentioning the titration, how manual CPAP titration was done, what mask was used, and what was the saturation after using that, and what was the AHI. We're giving the PLM, we're giving the ECG, even if it was normal, and concluding with the final diagnosis, where we're mentioning that this patient had sleep disordered breathing, what was the severity of the OSA, what was the severity of desaturation, how he responded to the PAP therapy, what was the pressure, what was the mask, and it must end with a recommendation. Like in a diagnostic study, we would end up recommending a titration study. So the importance of this summary is you are actually telling how valid it is. You're telling about the overall quality of sleep. You're telling about the severity and the phenotype of the patient. You're also mentioning hypoxia. You're also giving directions to treatment. The common mistakes one would make, however, in reading a PSG would be over trusting in AHI, ignoring the sleep time, ignoring the efficiency, ignoring the REM data, ignoring the position, and not seeing the raw data where there may be errors and will ultimately lead to errors in your final report. With that, there may be circumstances where you will have a negative sleep study, but you were expecting a positive sleep study. If you think that your patient is a very high suspect of a particular sleep disorder, and you did not have the right result, you may actually have to repeat the study. That can come when you did a very small study, say the time patient hardly slept, or you couldn't record REM in that patient because he was too conscious, too alert, he did not sleep well in supine, he had some pains and aches limiting the study, or it could be the first night effect when the patient cannot sleep well in a sleep laboratory, or it could also be the night to night variability effect, where one night's sleep may not be representative of the other night's sleep. And patients usually may have a different sleeping pattern than their usual pattern when they are in the sleep lab. Sometimes a reverse first night effect also happens when the patient actually sleeps better in the sleep lab compared to their house. And that can happen in patients who have a psychophysiologic insomnia, or these patients may actually be feeling that they don't get sleep when they are at home, but in the sleep lab, they might actually end up sleeping well, which also tells us that there's no physiological problem going on. These are three case scenarios where what I want to show you is that sometimes you may not have a very high AHI, like in this patient, the first one, but his time spent less than 90% saturation is very high, almost half of the study, with a very low SpO2, and you may want to treat this patient because he's symptomatic. In the other one, if your AHI is too low but your RDI is too high, it may be a sign of UARS and may need management. And in patients like those with heart failure with CSR, you see Cheyne-Stokes respiration, you see central events, but you know that your patient clinically has a low ejection fraction, then you may need to give a BiPAP therapy, and you may not be giving an ASV because you know the ejection fraction is too low and is contraindicated. So a lot of conclusions can be made if you take those things together. So when you get a case or a study to report, you see the clinical history. You look at the hypnogram, which gives you a lot of information in the first go. You look at all the analysis after the sleep architecture. You look at the respiratory analysis. Make sure you see the raw data to confirm whether the events have been scored correctly or there could be errors. And in case the titration is done, you look at what pressure may be best for your patient. With that, sometimes you may get level 3 studies for reporting, and in certain individuals where you have very, very high suspicion of an OSA and the patient does not have comorbidities, a level 3 study may be done. But what you will lose is not knowing about arousals, not knowing about the actual sleep time, not knowing about RERAs and the RDI, and certain technical issues. So we may not recommend a level 3 study in all patients. Specifically, the ASM rules out home sleep apnea portable testing for patients with comorbidities. You can only do it in patients with very high suspicion without comorbidities. But then you can use this study for a lot of individuals who are otherwise healthy. So with that, 10 take-home messages for reading a PSG is to always check TST first. not correlating AHI and severity, looking at the hypoxic burden, the various phenotypes, looking at arousal indices, looking at the raw data yourself, correlating clinically, thinking the phenotype, and treating the patient as a whole. I hope that you liked this presentation, and though it was a little away from Pulmonology Read Aloud's essential series where I read aloud information, I hope it adds to your practice. And thank you for the PG residents who asked me to upload this. So here you go. Thank you, happy reading, and enjoy visiting the Pulmonology Read Aloud YouTube page. Bye bye.